that he diagnosed via screening. I would like to give the story of this patient in details. He was 21 days old, born in Konya. Her parents are first-degree cousins. He born at 38 weeks of gestation, a bit small, with normal upgrade. He has one healthy sister. She was 5 years old. And he had a fever and cough at the second week of his life. And pneumonia and septicemia diagnosed. They went to an hospital. And at this hospital, intravenous antibiotics and respiratory support given to this patient. When we got from his gut record that he has a SCID, we find the patient at this we find the patient in this hospital, and his physical examination. He came to our clinic. We transferred him to our clinic, and at that time we see that he has really respiratory pneumonia, respiratory disease, respiratory infection. And at that time, on his first examination, the whole blood count revealed the severe lymphopenia, as you see here. What was the cutoff? 3,000, yes. It's 240 millimeters. The other whole blood count are normal, other parameters. Uric acid is low, and IgG low, and A and F is a pan-hypogammaglobulinemia. And when we look at these lymphocyte subsets, there is no T cells, no T cell subsets, no B cells, some NK cells, and we also conducted the flow cytometry with CD4. The cells expressing CD4, CD45 RA, and CD31 are the Treg cells, which is again 0. There is no T cell receptor, no T cells, no T cell subsets, no B cells, and some high NK cells. So this very first patient diagnosed by screening revealed a T negative, B negative, NK positive phenotype of SCID. And when we look at the genetic diagnosis, we saw that he has an ADA deficiency, ADA deficiency. ADA is a metabolic disease, as you know, ADA deficiency. ADA enzyme functions in the uric acid pathway, and if ADA is missing here, then no inosine and deoxyinosine appear, and adenosine and deoxyadenosine is increasing in the body. And these metabolites do what? Produce toxic effects against lymphocytes, and lymphocytes progressively died with apoptosis. That's why is ADA showing as SCID phenotype. There is no defect in T cell production, but because of these metabolites of ADA enzyme defect, the lymphocytes died with the toxic effect with apoptosis. And the clinics is exhibit. How do we treat these patients? At first, we treated him with enzyme replacement to increase the lymphocyte levels and to keep him safe until the curative treatment conducted. So the curative treatment is bone marrow transplantation. If there is a matched sibling or matched family donor, proceeding with bone marrow transplantation. But if there isn't any matched sibling or matched family donor, at the moment the algorithm is getting you to gene therapy. Until gene therapy, we are also using IVIG and enzyme replacement and prophylactic antibiotics like Bactrim, like antifungal and antiviral prophylaxis, and IVIG replacement and with enzyme. Then you have to proceed with gene therapy if possible. Yes.
Can I ask a question?
Yes.
So, if I understand correctly, in ADA deficiency, there's no problem in bone marrow production. The produced cells are due to the deficiency, there's like a problem in the after the production. When we do the therapy in bone marrow transplantation, then the new cells will also get killed by the metabolites.
The new cells, sorry.
Transplantasyon sonrası yine aynı sıkıntı olmaz mı? Hani uzaya başladığında hastalığı kendisi aklı bone marrow vardı. Bu sıkıntı bağlı olarak onlarda sıkıntı düştü. Yine biz bone marrow transplantation yaptığımız yine ADA deficiency devam etmiyor.
Yok, aynı zamanda tinus'ta mekanik değil de etkileniyor bu hastalıkta. Oradaki hücreler yani sadece olduğu tinus, olduğu şey gitmiyor. Nefesler gitmiyor. Totally. It affects totally the immune system. That's why. No, it's not. You're changing the surface. Yani circuit'i kırmış oluyorsun sen bir şekilde. Yeni bir şey başlıyor. Immune sistem gelişimi başlıyor. Artık ADA metabolikleri de onlara da baktığın zaman onlar da yüksek oldu. Yes, this is the first patient born in pneumonia, second child of Finnish parents, diagnosed, family informed, isolated, defective gen identified, and treated by gen addition, gene addition. For the second patient, there are dizygotic twins, born as a mild preterm in Ankara, and they have the severe combined deficiency with T negative, B negative, AK positive immune phenotype again. In this case, RAG1 defect identified and treated by multiple stem cell transplantation from the twin, with the cells of twin. This is the patient, this is the healthy twin. Can you see the difference? We waited for 9 months to get the donor mature and weight gain. When they became 9 months, we transplanted. This is donor, and this is the patient, and this is the patient now. She is much, looks like the same, they are much the woman, they are doing well and alive. Okay, so, 9 months, 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 9 mon identified the primary immunodeficiencies as a, how do you say? Iceberg. The part you can see is much smaller than the part inside the ocean, and so we need to be suspicious. We need education, and we need diagnostic centers. And the most common mistakes for the delay in diagnosis are not to think PID. Physicians are thinking like this: oh, they're a rare disease. How do I find it here? You know, it's impossible. Let's say, not to think about this. Avoid PID. They don't like PIDs because they're usually severe diseases, and the patients are demanding patients. They like to ignore PIDs. This is the same all over the world. And interpreting the medical history, physical examination, and laboratory results incorrectly. It's very important then to know which is normal, which is not normal, which is abnormal, what should be asked to the family, and to make the general whole physical examination, and to see the lab results timely, and to determine the results, to see the results are very important to avoid late diagnosis. So for feature, we need very early diagnosis, definitely, effective treatment, and national impulsive program. When we came to the principles of treatment in PIDs, early detection of infections, any kind of infections, and prompt and aggressive treatment plans are very important. Also, preventing infections, avoiding organ failures, and preventing malnutrition, supporting their growth and development is important. For the treatment, we have specific modalities which are mostly curative, and we have supportive therapies and protective approaches. Among these specific and curative treatments, IG replacement is very unique, very important. We are giving IgG to these patients, which they cannot produce themselves. And this is a biologic product, of course, and a very unique product. And by IG replacement, many patients improved the quality of their lives and came to adulthood for antibody deficiencies. Hematopoietic growth factors, we can use them whenever needed. Also some cytokines, enzyme replacement like ADA for ADA deficiencies. Granulocyte transfusions whenever needed, or biological agents. Hematopoietic stem cell therapy and gene therapy are the most important, most effective curative treatments, of course. We can transplant the patients with severe combined immunodeficiency. It is mandatory, I think, because these are pediatric emergency patients. SIPET is a pediatric emergency. Also, in different forms of combined immunodeficiencies, we can transplant Olsen syndromes, blood patients, MHC class 2 deficiency patients that we talked yesterday, as you remember. Bare lymphocyte defects, SCOTs, CGPs, PNPs, DOC8, alignment defects, and many others can be cured by hematopoietic stem cell transplantation. SCID is a pediatric emergency and patients die around 1 year of age. Natural history is very severe. So bone marrow transplantation should be performed for all of them. But early transplantation, early period to 3 months, either identical or non-identical transplants are life-saving. It has been shown in our data also. This is the clinical features and hematopoietic stem cell transplantation outcome for in Turkey. There are more than 200 patients here from 8 centers. This is a multi-center study. The age of diagnosis is 5 months, which is not good, as you see. But these results, these patients are from 1994 to 2014. Age of transplantation is 7 months. And overall survival is about 66%. And it, of course, increases by the time passes. Significantly improves. But it's not enough, of course. We need to yield much better results. This is our single center results. 72 patients is there, 61 patients transplanted, and 11 died prior to before transplantation, and symptom onset is 1 month, age at diagnosis is 3.5 months, age at transplantation is 5 months, and you see that the patients, most of the patients are lymphopenic at diagnosis. BCG activation is very common, and T and B cell negative phenotype is common. And the results are interesting and very striking, as I say. Survival is 100% if the patient is young and free of infections before bone marrow transplantation. So the age and the presence of active infection is not good. They are the prognostic factors, main prognostic factors for the transplantation of these patients. Older patients, 3 months, more than 3 months, and with active infection, the transplantation success dropped to 75%. This 100% is very important because the person is surviving. The child who is going to die in a year time is surviving totally. There is no other disease like this in the medicine. For supportive therapies, nutrition is important. Blood and blood products and antimicrobial agents can be used for supportive therapies. For preventive approaches, irradiation of blood products are important because we can easily lead to graft versus host disease. CMV is a big problem, but there isn't any CMV negative product in Turkey because CMV is like EBV, very transmitted very early time of the life in childhood. Most of the children are positive for EBV and CMV. Special vaccine implementation is required for these patients, and prophylactic antibiotics and prophylactic sometimes, very rare, but sometimes we need prophylactic RG as well. All live vaccines are contraindicated in all combined immunodeficiencies and T-cell related PIDs, especially BCG. This is the first patient of our unit who had transplanted in 1997, a baby girl 6 months old with SCID, JAK3 deficiency. We transplanted her from his brother, who is healthy and 7 years old. Everything was okay until the 14th day of transplantation. At the 14th day, 6 weeks after the transplantation, infusion of the cells, the baby got fever. And fever of unknown origin, we couldn't find the reason, we couldn't find any microorganism. And for a long time, she had fever, and afterwards, she, as you see on her hands and on her shoulder, left the abdomen part of the body. And you can easily see the X-rays with defective biopsy. We got biopsy from this area, and find the microorganism, which is mycobacteria, BCG disease, bovis, mycobacteria, Mycobacterium bovis. So, she got treated for 3 years with multi-agent antituberculosis drugs, and she couldn't hear well at the moment. She's a nice girl, but she is using hear device, unfortunately. That's why we have to diagnose them early before BCG vaccination. Otherwise, BCG became life-threatening, even decreased the quality of life in somehow in these cases. This is another patient with PMP deficiency, developed lymphadenopathy after engraftment. You can see here again BCG disease. So vaccination is really contraindicated with live vaccines in this kind of patients. However, how about vaccination after bone marrow transplantation? After the immune functions appear again, immune reconstitution happened. We use all the vaccines except BCG and smallpox in these patients. We use all the vaccines after immune reconstitution achieved. Vaccines are not beneficial in severe antibody deficiencies also. All vaccines other than live ones can be applied to patients whom enough antibody responses could be achieved. All routine COVID-19 vaccines are applied to patients with phagocyte and complement defects other than BCG. Again, phagocytic defects, we don't use BCG vaccination. For the follow-up, we try to provide optimal treatment, also of course, keep eye on growth, nutrition, food intake arrangement, and we try to protect against all kinds of infections and try to prevent organ failures. Also, psychological adjustment of patient and the family to the disease and its requirements are very important. Genetic counseling and perinatal diagnosis is also important. So, in summary, I would like to say you that PID covers a heterogeneous group of disorders, disease, not a single disease. A hidden health problem in Turkey and likewise countries, not rare, common, due to the high rate of consanguinity. It can occur at any age and anywhere, does not always present with severe infections. Awareness and high suspicion index are mandatory chapters for early diagnosis. And white blood cell count and screening test and first line test are highly valuable for diagnosis. And laboratory results should be interpreted correctly, even if they are found to be normal or non-diagnostic. If the clinical phenotype is saying something to you, the presence of strong clinical phenotype, always needs to close follow-up and expert counseling. Yes, they're stronger than before. I have a very nice group. I'm not doing all of these things, of course. I'm not looking after all of these patients. I have a nice group, nice physicians, nice doctors, nice laboratory technicians and nurses. You may know most of them, I believe. And also, we are very lucky that we have Mustafa Kemal Atatürk. We have him ideas, we have his ideas and his wisdom. Thank you. Any questions? Yes.
Why the BMT is why there is a cutoff like 3.5 months for BMT?
It's not a cutoff. It's what
Because of vaccines.
It's not a cutoff at the moment. It was a cutoff before newborn screening. At the moment, according to the studies, the presence of active infection and agent in the time of BMT is important. And as early as possible is perfect. In Turkey, we have to be before vaccination, definitely. So we have to deny before 2 months, because 2 months is for the time for BCG. We have to pick. We have to beyond BCG. Yes.
Do we do delay vaccines after transplantation? Or not we transplanted to the patients?
Yes, other than BCG and smallpox. For example, of course, oral polio is also contraindicated, but we use inactive polio. We use also measles after transplantation.
Oral polio and BCG and smallpox is not used.
No, yes.
How long do we need to wait for the vaccine?
Yes, after the new reconstitution, after the patient fully reconstituted. It usually in match sibling donor or match family donor transplantation after the first year. In healthy transplantation after the second year, usually. because immune reconstitution is a bit late in different type of donor transplantation. Yes? Başarılar diliyorum sınav için ve hemen exam. At 1:30